Now let's deal with acute inflammatory demyelinating polyradiculopathy. Now this is just the most common variant of Guillain-Barré syndrome, which affects multiple peripheral nerves through an autoimmune response that destroys Schwann cells and in turn the sheath. Now, weakness is more pronounced than sensory deficits, and this is one way you should start thinking about it. Guillain-Barré syndrome starts out as a symmetrical sensory, motor, or mixed deficit, and it usually starts distally and then ascends proximally, and it can involve one or both sides of the face. So, what tests would you perform to reach a diagnosis? Well, the diagnosis is made by the clinical symptoms I just described and increased protein in the CSF. You would also see changes on the EMG that would correlate to the muscle weakness that you see in the disease. It has an unknown etiology, but sometimes it follows infections, vaccinations, or surgical procedures. So what is the classical infection associated with GBS? Well, that would be Campylobacter enteritis. Now, herpes virus infection can do it as well. The pathogenesis is thought to be autoimmune due to molecular mimicry, and thus GBS can occur a few days to a few weeks after the initial infection. These patients must be hospitalized because they develop autonomic instability, and if the diaphragm becomes affected, then you need to provide respiratory support. This graph shows the range of symptoms and how it can change with treatment. So in this graph, on the y-axis, we can think of it as functionality with no weakness to the top. So this is kind of your best case scenario, and then paralysis, which would be your worst case scenario at the bottom of the y-axis. And then on the x-axis, we're simply looking at a progression of time. And so in the red case, you can see that this is sort of a mild case that spontaneously resolves. So it's not too much of a big deal. In the black case, however, this would be kind of the worst case scenario where you have a rapid degradation of functionality that just stays poorly for a number of months. Now, what you will see here is that this blue line is representing when patients are treated with either IVIG or plasmapheresis. Now, the exact mechanism of IVIG in autoimmune disease is not really known. However, it is thought that the antibodies given might form complexes that activate Fc receptors, and these are found on dendritic cells. Now, when these are activated, you would have an anti-inflammatory response. Plasmapheresis removes antibodies from the plasma, so it gets rid of the antibodies that are causing the autoimmunity. So you can see by this graph that treatment not only stops symptoms from progressing to a certain degree, but they can also help you have a significant recovery, but this takes a course of weeks to occur. Now, most patients will have a good recovery, but it takes months to reach back to baseline. You should also know that in addition to the therapies I mentioned, plasmapheresis and IVIG, you can also provide supportive therapy for symptom relief. Now, the disorders mentioned in this entry are relatively rare. You aren't as likely to see a question about these as dementia, stroke, or MS. But remember, everything covered in first aid is fair game. Progressive multifocal leukoencephalopathy is the demyelination of the CNS that occurs due to destruction of oligodendrocytes, and this happens due to reactivation of the JC virus. Now, here you can see a histological side from the brain of a patient with progressive multifocal leukoencephalopathy. Now, what do you notice about some of the oligodendrocytes in this slide? Now, you should remember that oligodendrocytes are thought to look something like a fried egg, and that should help you identify them on slides. So we have a nice example here, maybe here, here. You should be able to kind of get the hang of the fried egg appearance. Now, you should have noticed something about these oligodendrocytes, and that is that most of them, or at least a great proportion of them, had these pink nuclei. Now, these are the cells that are infected with the JC virus. JC virus is almost ubiquitously found in the population, but it stays latent until reactivation, which mainly occurs in immunocompromised patients. And these are your patients with maybe things like AIDS or transplant recipients. These patients will present with a number of different symptoms. You can have altered mental status, aphasia, ataxia, hemiparesis or hemiplegia, and visual field disturbances. Now, the variety of symptoms you get is simply the result of which part of the cortex is being affected. So, for instance, if you had a deficit in the visual field, where in the cortex would you expect the deficit to be? Exactly, probably the occipital lobe. Right, so these are the types of things that you should be thinking about. If you see a certain defect, where in the brain is the function for that specific thing, and then when you have a deficit, it's because you have a lesion in that part of the brain. Now, for diagnosis, you should obtain a PCR for JC virus from the CSF. The prognosis is actually quite poor, with death occurring 3 to 6 months after the onset of symptoms, and that's a very fast time course, so you should definitely try to remember that. Acute disseminated encephalomyelitis, or ADEM, refers to the neurologic sequelae of infectious fevers, such as measles, rubella, smallpox, or chickenpox, and vaccines, notably the live rabies vaccine. Now, it is thought that the acute inflammation instigates a demyelinating disease through the brain and spinal cord. As you can see on imaging, it looks very similar to MS with hyperintensities of the white matter. However, it is distinguished on the basis of temporality. Now remember, we said that MS has lesions that are separated in time and space. Those in ADEM should occur all at once. ADEM is more pronounced in children. It's another way that you can distinguish it from MS. Patients with ADEM usually present with neurological symptoms as the acute infection is resolving. Usually there is altered mental status, headache, fever, and ataxia. Treatment is primarily with steroids. As with other autoimmune things, you can also use IVIG or plasmapheresis. Metachromatic leukodystrophy is an autosomal recessive inherited lysosomal storage disease which affects the myelin sheath. The prognosis is actually pretty poor in most patients. They frequently die within the first 5 years of life. Those who do survive to adolescence often have impaired school performance, progressive dementia, or a psychiatric disorder. On imaging, as seen here in this FLAIR MRI, the hyperintensity is much more symmetrical than you would see in other disorders like MS. The thing to remember about this disease is that it's one of the lipid storage diseases that have neurological effects. So what is the missing enzyme in this disease? Aryl sulfatase A. I'll spell that out. Aryl sulfatase A, or ASA. Now, ASA is important for converting sulfatides into galactocerebroside. Thus, when it is absent, as seen in these graphs of a study in knockout mice, you get a buildup of sulfatides. So sulfatides here on the y-axis. In mice that are lacking this enzyme, illustrated here by these blocks, you see a buildup of the sulfatides. Now, this is important because as sulfatides build up in Schwann cells, the uncleared lipid metabolites damage the myelin sheath, and this is what leads to the mental and motor impairment. So what sort of symptoms would you look for? Well, here you should be looking for an infant with motor delay. As a result of that, you probably have frequent falls and abnormal posture. The chart that outlines all of the lysosomal storage disorders is one that you should definitely make sure you know. These are often tested and they're really easy points to pick up, but only if you know what you're looking for and have put in the work beforehand. Charcot-Marie tooth is the most common inherited neuropathy. It represents a heterogeneous group of disorders that share the same clinical phenotype, with progressive weakness of the distal muscles in the limbs, with or without sensory loss. Over time, it can result in atrophy of the muscles, as seen in this picture here. There may also be pes cavus of the foot. Now, pes cavus simply is referring to an abnormally high arc in the feet. In addition, you will see reduced or absent deep tendon reflexes, There are two types. Type 1 is demyelinating and type 2 is neuronal. Unlike muscular dystrophy, which actually affects the muscles, Charcot-Marie-Tooth affects the nerves that innervate those muscles. The deep peroneal nerve is usually involved. So when you get a question stem that mentions the deep peroneal nerve, you should definitely be thinking about CMT, Charcot-Marie-Tooth. Now I mentioned that there were two types of this disease, and in both types they relatively spare the sensory neurons, but occasionally patients can experience pins and needle sensations in the hands and feet. Patients with CMT have normal cognitive functions, and they usually have a normal lifespan. There is no current treatment, but patients can be helped quite a bit by providing physical therapy and supportive care. Lastly, I want to briefly discuss Krabbe's disease. This is another autosomal recessive lysosomal storage disease, similar to metachromatic leukodystrophy. Now, it occurs due to mutations in this GALC gene. So we have a mutated gene, and what that leads to is a deficiency of galactocerebrosidase. Okay, so we have a deficiency of that because we have a mutated gene. Now, because this enzyme is unable to perform its function, we get a buildup of galactocerebroside. Now this, similar to the case in metachromatic leukodystrophy, will destroy your myelin sheath. Now the symptoms can include irritability, fevers, seizures, difficulties with feeding, and kind of a slowing of mental and motor development. And actually this is important clinically because sometimes it can be confused with cerebral palsy. You should really take the time to memorize all of the enzyme deficiencies in autosomal recessive lysosomal storage disease. This is the second time I'm saying this. They are commonly tested, and with a little hard work, it can lead to a big payoff. The enzyme that is deficient or the product that builds up is usually going to be a key fact in the question, so if you know what you're looking for, it's easy points. Adrenoleukodystrophy is a X-linked recessive disease. It results from mutations in the ABCD1 gene. Now this is the gene for a transporter that carries very long chain fatty acids, VLCFAs. Without this transporter, similar to some of the other disorders we've just talked about, you get an increase of these VLCFAs in organs around the body. However, the white matter of the brain, the Leydig cells of the testes, and the adrenal cortex are usually the most affected organs. Here we see an MRI that shows volume loss and increased signal intensity within the white matter. This is consistent with the disease. However, testing for increased VLFCAs as well as genetic testing would be needed before you could actually definitively make that diagnosis. Now, there's a wide range of symptoms that can occur, including emotional instability, hyperactivity, muscle stiffness, paraparesis, and adrenal insufficiency. Now, symptoms are so varied that they are often not even the same within members of the same family. This disease has been seen in the popular media through the movie Lorenzo's Oil, which you may have heard of. The oil that the family creates for their son who has the disease turns out to work because it is loaded with fatty acids, which compete as a substrate for the enzyme that creates very long chain fatty acids. So due to that competition, you get a decrease of VLCFAs and an improvement in symptoms. Alright everyone, it is time for another flash quiz. And the question is, what infection is associated with Guillain-Barré syndrome? The answer is Campylobacter enteritis.